Hello, everyone. I'm Lillian Kell, President of IFSO, and I would like to extend a warm welcome to all of you who have logged on to this first of a series of webinars from IFSO on what has been a challenging and unprecedented pandemic. Today, we have representatives from different chapters around the world to report on their respective experiences on how the coronavirus pandemic have impacted their bariatric surgical practices and the way they approach their patients. What we see in one country may be what we expect to see in another country tomorrow, depending on the position of the curve of the pandemic of the country. Firstly, I'd like to welcome our panelists from the IFSO North American chapter, Dr. Marina Kurian from New York, which is now the epicenter of the coronavirus pandemic in USA. Welcome, Marina.
Thank you.
The IFSO European chapter, Dr. Luigi Angrisani from Naples, who's also chair of the Board of Trustees of IFSO. From the IFSO Middle East North Africa chapter, Dr. Khalid Mirza, who's also president of the chapter from Saudi Arabia. From the IFSO Latin American chapter, Dr. Elmino Ramos, who's our past president from Brazil.
Yes, hello guys.
Hello, Amino. And from the IFSO Asia Pacific chapter, I'd like to welcome Dr. Ping Zhang from Shanghai. Now, each of our speakers will take 10 minutes to summarize from their experiences, what to expect from this pandemic. They will share with us what they are seeing today and what we can expect to see tomorrow. They will talk about how to prepare yourselves as health professionals, how to continue to care for our patients, what surgeries to prioritize, and look at evidence versus myth in each of our practices. I also would like to welcome our two discussants, Dr. Antonio Torres, also a past president of IFSO from Spain, and Dr. Bassam Safadi from Lebanon, a member of our scientific committee. For today's presentation, we will run the presentations from the experiences of each chapter. So we'll start with the Asia Pacific chapter, followed by the European chapter, the North American chapter, the Middle East North African chapter, and Latin American chapter. Before we start, I'd like to do the first poll, which our presenter will show you, and I'd like you to read the poll and poll in your answers. So the first poll is, how has your practice been affected by the COVID-19 pandemic? And choose one of the following. Everyone, have you voted? If you have, then we'll look at the results of the first poll. Okay, so the majority of you, 48%, have said that your practice have shut down and mainly provide emergency and urgent inpatient services. So thank you for that first quick poll. Now we're going to start with our first presentation from China. China was the first to experience this pandemic in the epicenter of Wuhan. Wuhan has been through the worst and survived. And I would like to invite Dr. Ping Zhang to tell us about his experience. Thank you, Dr. Zhang.
Thank you. Thanks, Lillian, for the introduction, and also thanks IFSO for giving me this opportunity to share some of our practice and my personal thoughts during the COVID-19 pandemic. My name is Ping Zhang Charles from Beijing, China. Actually, I moved to Beijing last year. I'm the chief of metabolic bariatric surgery at the Beijing Friendship Hospital of Capital Medical University. Today, I'm going to talk about 5 points. Where are we now? What we have done so far, and what are we doing now? And actually, next one, 4 points, sorry. What will we expect to do tomorrow? Let's start from the first one. What are we now? Where are we now? As of yesterday, there are more than 1.3 million confirmed cases in the world, and yesterday there are more than 72,000 new cases were recorded yesterday, and this is a timeline of COVID-19 outbreak in China, starting from mid-January till now. More than 83,000 confirmed cases were reported, and more than 3,000 deaths was recorded also. And based on the CDC's respiratory disease mathematical model, so you can say the pattern of COVID-19 outbreak can be separated into the pre-pandemic intervals and pandemic intervals. In the pre-pandemic interval, people start to recognize the disease, and in the pandemic intervals, there are 4 phases. One is initiation phase, then followed by acceleration, deceleration, the preparation for the next outbreak, and all about 4 phases. And if we fit this curve, this model into Chinese outbreak, it fits very well. You can see all the phases fit our timeline very well. Say from the January 18, the outbreak starts to accelerate in China. The acceleration phase lasts for almost 4 weeks till the February 12, and then reach the peak, then start to decelerate. After another 4 weeks, on March 7, the deceleration phase went to the end. And if we overview the outbreak of COVID-19 in different continental, you can see Europe and the Eastern Mediterranean are about 6 weeks behind China, and the Americans and Southeast Asia and Africa are about 8 weeks behind China. And COVID-19 has challenged our healthcare system badly. If we take a look at the timeline of outbreak in China, on 23rd of January, Wuhan city was locked down, which is epicenter of COVID-19. Starting from January 25, most of hospitals in China discontinue elective surgery. And after almost 2 months, in the mid-March, we start to resume the elective surgery, but with the very strict COVID coronavirus screening. And we are happy to know that Wuhan was reopened 2 days ago after almost more than 2 months lockdown. They reopened. However, we don't know when we will be able to perform elective surgery without any restrictions in future. Okay, now let's proceed to the second point. What have we done so far? I'm going to talk about some of our practice protocols during the phase of acceleration, deceleration, the early post-deceleration phase. And the strategy actually was to get prepared for the worst scenarios, including the minimize, postpone, or cancel elective procedures, endoscopies, or other invasive procedures, and minimize using essential resources, include PPEs, inpatient beds, ICU beds, medical equipment, and the cleaning supplies and the blood transfusion. Try to minimize using that to get prepared for the crisis, and also wear for the person and the healthcare professionals to wear appropriate PPEs in healthcare facility based on the exposure levels. The level 1, 2, or 3 protections are required. And also one of the other strategy was to minimize working hours of healthcare personnel. Let them stay healthy and did not burn them out and get prepared for the crisis. And we classified all the surgery into 3 categories, including emergency surgery, semi-elective surgery, and elective surgeries. For the emergency surgery, if you delay the surgery, might forever damage a patient's health, significantly reduce the functioning, or cause death. Semi-elective surgery give you a window to postpone the surgical procedures and the elective surgeries can be performed anytime. And also we classify the patients into 3 cohorts. One patient, cohort A, is a suspected or confirmed COVID-19 patients. The patient B, the patients under quarantine, which is cohort B, and the cohort C, which they are confirmed without COVID-19 infection. For the patient with emergency or urgent condition, we need to classify patient first, including cohort A, B, or 3. If patients are classified into cohort C, meaning they are safe, they are not infected, can continue to do the emergent or urgent surgeries. And a patient just fall into the cohort A, which is confirmed or suspected cases. If their cases are elective or semi-elective, maybe you can cancel or postpone surgery. If they're in emergency condition, then go to the emergency surgery. The patient cohort B is also have a life-threatening condition and go to the emergency surgery. If the condition is semi-elective, to the further COVID testing. And if this is suspected or confirmed cases, can postpone surgery, or if they are safe, they are not infected, can go to surgery. But remember, when you do for the cohort B and the cohort A patient, you do the emergency surgery, level 3 PPE are required. And the strategy on the cohort A and the cohort B patient for the emergency condition in the 3 parts. Once transferred to OR, then you need to designate patient transfer route and use appropriate PPEs during the transfer. The patient needs to fully covered, appropriate face masks used, and spray the disinfectant following the patients. And in the OR, use the negative pressure OR, and use the appropriate PPEs, and the level 3 PPE are required, and the disposable container. After surgery, cohort A patient transferred to designated hospitals. In the cohort B patient, we're just waiting for the RNA results in the OR. If negative, transfer back to ward. If positive, we transfer to the designated hospitals. We treat the COVID patients there. And for our society also has a guideline for the COVID-19 for the bariatric surgeries. And now the China is big, have many 30 provinces, so each condition quite different. So we just classify all the province into 5 levels. And the top level is the province with more than 10,000 cases, and the level 4 is 1 to 10,000 cases, and level 3, level 2, and level 1 is like just less than 100 cumulative cases. So we review this number almost every day. So our guideline is that for the level 3 through level 5, and we should avoid elective bariatric surgery. For level 2 province, we're going to practice bariatric surgery with cautions. And for the level 1 province is meaning there's low risk, so there's we just perform the bariatric surgery. And so all patients must undergo screening protocol, even for the level 1 province, and then patient travel across the province are discouraged. And any hospital in any level province with a confirmed cases then should avoid bariatric surgery. And then let's talk about what are we doing now. So as we know, now we are in the preparation phase, preparation for the next outbreak. And this phase, then our elective, semi-elective surgery has resumed. But for every patient go through the COVID screening. And if this patient cohort C, they are not infected, just continue surgery. If we fall into patient cohort A, we have to postpone the surgery, bariatric surgeries. And if the cohort B, we need to wait another 2 weeks, then re-screen the patient to classify them again. And the screening protocol, including the patient history, the symptoms, including fever, cough, shortness of breath, etc. And also we test the CBC and the CRP, and do the chest CT routinely. If suspected, we may do the RNA testing. So the other message for the bariatric surgery practice during the COVID-19 pandemic For patients, so we have some points. So we try to encourage patients to have surgery in their local hospitals. So the must wear at least level, patient must wear at least level 1 PPEs in medical facilities. This stay in a single patient room and without any companions. For our healthcare practitioners, we should wear appropriate PPEs in medical facilities all the time, and try to the simpler procedures preferred. For instance, the sleeve gastrectomy is more preferred over other procedures. And the surgeons must have enough experience to do the surgery during this period of time. They try to shorten the OR time, and the ERAS fast track protocol is highly recommended. And we during all the phases we continue to take care of our patients through the online seminars, tele-consultations, and also we try to encourage patients to go with a non-surgical weight loss approach. And then go to the final point, what will we expect to do tomorrow? So we don't know yet. So we try to keep the optimistics, and tomorrow will come for sure. We just cherish the hope. And for our healthcare personnel, we try to continue to stay healthy, to serve our patients better in future. And we are sure we are going to be busier tomorrow than any time in our practice. And thank you so much for your attention. And the final words that humankind will win the war against any organisms. Thank you all. Good night.
Thank you very much, Dr. Zhang. That's very optimistic. I'd like to invite Antonio and Bassem to discuss the presentation.
Charles, Dr. Zhang, congratulations, nice presentation. I have a question for you regarding the status of your situation now. Do you have any information regarding the patient concern of being operating again for bariatric surgery? Do you have any information about if the patient wants to be operated again or start the operation? Do you have any information regarding this topic?
I'm sorry, the signal is not clear.
My question is, do you have Charles, do you have any information about the patient's concern for being operated now or later on?
Yeah, so we provide a safe environment for our patients. That's number one. Number two, then the patient now they are quarantined. They stay home. They have enough time. So they want to get surgery now. It's the overall environment is quite safe in China. So we now have each week now we have more than 20 per week. But a month ago, we tried to encourage patients to stay home, no surgery. Now we just admit patients freely after the screening.
Okay, I have another question before giving the word to Bassem. The question is, do you have any data regarding an increased morbid mortality in obese patients with the COVID disease?
You mean what's the mortality?
I mean, is obesity a negative prognostic factor for being infected or not?
Sorry, my signal is bad. I can't hear very clearly.
Okay. Now the question is, do you consider, Dr. Zhang, that obesity itself, overweight and obesity, is a negative factor for increasing the mortality of the patient under this epidemic?
Your question that the patient has
like the age, older people are more.
Your question is that the patient with obesity has a higher mortality rate than normal body weight patients.
Yeah.
Yeah, I don't have those information, but based on the physiology, pathology that for sure the patient with obesity must have a higher mortality rate during if they infected with COVID-19. And based on the theory, but we don't have those statistics.
In Spain, we have the sensation that in intensive care units, mortality is higher in obese patients because it's much more difficult to put them on prone position for ventilation. So this is an important topic in my opinion. Okay, then let's go.
Yeah, but we don't have those statistics in China.
Thank you, Dr. Peng.
Thank you.
Can you hear me well?
So
this is Bassem Safadi. So from the poll we heard, about 90% of bariatric surgeons have their practices on hold now. And most of us are waiting for us to pass through that curve and get to the recovery phase where you are in now. So you told us that you are screening your patients carefully before you decide to schedule any elective bariatric surgery. And in that screening, you mentioned CT scan of the chest. Is that standard on every patient?
Well, now it's become standard for every patient. You know, during the acceleration, the deceleration phase, and the early deceleration, post-deceleration phase, we don't admit any bariatric surgery patients. But now the environment is safe in China. We try to admit patients, but still with very strict screening protocol, including the history, symptoms, and the CT scan, and the CBC, and the CRP. And if they are negative, then we're going to admit them. If they are positive or suspected, we just encourage them to stay home. After they recover, then they come back again for another screening.
So as a follow-up to this question, did your clinic setup change? Like, is your seating between patient and patient different? Is your scheduling different? The number of procedures you do per day, has that been reduced? How are you coping now with issues like scheduling and organization of the OR schedule?
We just postpone every. You know, we have 2 months accumulated cases. We didn't do yet. So we try to accommodate their time. Their just our nurses talk with patients, try to schedule them. But we are in a almost full speed, starting from 2 weeks ago.
One question relating to surgical training. Do you have fellows who train in bariatric surgery in your program on hospital? What do they do when we have 3 to 6 months of no bariatric surgery? What should we do?
That's a good question. I don't know. For each hospital, there are different cultures.
What's your advice to countries where the pandemic has not hit hard or is in the pre-acceleration phase?
Based on our experience, just wait, just stay healthy, just wait. Including for the doctors, you have to stay healthy and also tell your patients to stay safe. Just waiting for the tomorrow. Tomorrow will come.
That's great, Dr.
Dr. Zhang, I have a question from the audience. One of them asked that there's a paper that shows that COVID-infected pre-symptomatic patients, when submitted to any form of surgery, have a 20% mortality. What is your uptake on that?
Any patient, 20% mortality. Well, I didn't read that paper. I don't know too much details about it.
Okay.
What's your thought? What's your thought?
Well, we don't know. We're just asking the question based on a report.
If I may, there was a paper published recently in Clinical Medicine from Wuhan, Hubei. The author is Dr. Lei, and he reported on a series of patients who underwent major surgery. It was elective, but they did not know at the time that the patients were COVID positive. And it's right in that series, 20% died, 44% were admitted to the intensive care unit. So these are scary statistics.
Yeah, I haven't read that paper yet, so I don't think I'm qualified for any comments on that.
All right. Thank you very much, Dr. Zhang.
Thank you.
Before we move on to our second speaker, I'd like to put up our second poll and ask the attendees to answer this. Has any patient or staff member within your practice been infected with COVID-19 virus? Please select one of the following. And let's see the results of this poll. Okay, so the good news is majority, 2/3 have not shown that any patient or staff member been infected with COVID-19. That's great news. However, there are 18% of which patients and staff members have been infected and 10% staff members. Thank you for doing that quick poll. Next, we will move to Italy. Italy has been caught unprepared for this pandemic and has been through a tremendous heartbreaking experience with the largest death toll of more than 17,000. I'd like to invite Dr. Luigi Angrisani to share his experiences. Thank you, Luigi. We can't hear you, Luigi. We see your slides, but we don't see you or hear you. We see you, but we don't hear you. Are you muted? Okay, while we are trying to get through this technical problem, shall we move on to our next speaker? Perhaps we'll get Marina, our next speaker, to present while Luigi gets through his technical problems. Okay, so we will move to North American chapter. We know that the USA is continuing to experience the uprising of the exponential curve. The largest number of people infected is in the USA with nearly 400,000, while the daily death roll continues to rise. So, Marina Kurian, tell us your experience.
So you're absolutely right that we have the highest number right now, but I do think that a lot of that has to do with testing. And so while we may be have the most positive cases, we may also be testing the most as well. Our first case in New York, where I lived, was identified March 1st. The patient actually came from Iran. As you know, we had many cases out in California and Seattle because of cruise ships and people traveling from Asia and coming over, and certainly from Wuhan, maybe the first cases were in Seattle. So we have been dealing with this for some time, but we, as Dr. Zheng said, we are definitely behind by several weeks. However, the good news for us, let me just click to the next slide. So this is worldwide cases, and this is all from today that I got the updates that we have over 14,000 deaths. But the good news for us is that many of our big cities had practiced physical distancing much earlier than perhaps other countries, not, of course, Italy. And I think that for us, our governor of New York really asked us to stop doing elective surgeries as of March 12th. And the implementation was left to individual hospital systems. And probably by that Monday, Tuesday, almost all the major health systems in New York were decreasing the number of elective cases, which I think really impacts what has happened with the hospitals and preserving ventilators and PPE, et cetera. So the next thing that I want to talk about is in New York, we do have the most. This is showing what's happening in the States right now. We have close to 150,000 confirmed. And you can see the, hold on one second, I just want to move this so I can see that our death rate is up close to 6,300. And what's telling, oh, I just lost my point, hold on. Can you guys hear me still? Oh, thank you. Okay, so next slide shows kind of the age group, which I think what we're doing a really great job of. And you know, I will also say that none of the U.S. doctors would be as prepared, except that we have been in contact with doctors taking care of patients in China as well as in Italy. There's been a worldwide sharing of information, which is so critical to how we address the first cases that we saw. Perhaps we also were prepared in terms of throwing a lot of different medication cocktails at the patients, and that would actually help maybe decrease our death rate. So I put this up. There are in the younger age groups some smaller percentage of death rate, but these are the highest percentage. And I think the data collection here is going to be very critical to how we proceed when we go back to doing surgery collectively. So you'll also see that, you know, that the male death rate is much higher, 61% compared to the women. And that is one other thing that we have to bear in mind when we see a patient that's male and has a significant disease. And then the other thing, this is all updated yesterday. The numbers for yesterday to today are not available until after 2 p.m., so I couldn't give you those. But you'll see that most of the patients had hypertension and diabetes, hyperlipidemia. These are the top three that we are seeing routinely in the patients that have passed. And then this, you know, we are truly the melting pot of the world. It's my favorite city in the world, and I'm happy to live here. You can see what our distribution is in New York City and also in New York State. As we get outside the city, it's not as diverse as it is within New York City and the 5 boroughs. But this is our distribution for ethnicity. So I want to put this up. I got this from Dr. Henneford and colleagues. They put this out. It was a download of over 50,000 people had downloaded this, but this algorithm I thought was really fantastic. And it just kind of shows what we should be doing. And this was put out about 2 weeks ago now. And what we should do if we have a positive patient versus a negative patient. So currently in New York, no one is doing elective surgery. We're only doing urgent or emergent cases. And that falls under any perforations, any cancers that cannot wait at least minimum of 2 to 3 weeks. And so there are patients that have cancer that are being put off because they can hold off for about 2 to 4 weeks. The plan in the city and amongst the hospital systems is to perhaps resume elective cases in the early May to the second week of May, and that's a moving target. You know that the President of the United States has said to extend the sort of stay at home and social distancing till April 30th. And many elective practices around the country for bariatrics are completely shut down, and it is a financial crisis for everybody, not just the surgeons, but it is something that we're all dealing with and trying to understand what to do with staffing, et cetera. I think that most of the systems, and I work at 2 different systems in New York, that they will require COVID testing before any elective cases and before we resume. You know, you guys saw Dr. Zheng's slide, and I think that I'm going to stop showing my screen right now. But I think that when we go back, we're going to go back again with positive testing for patients. We're going to have to triage them to the patients that are perhaps on the most medications and need the surgery more quickly. And also we're going to look at, you know, doing full PPE in the operating room, which includes smoke evacuation with filters. And I think that that is critical to go forward. But I think, as Dr. Zheng stated, we need to test. I don't think that for us anyway, for the next, even in May, June, I think we're still going to be doing it. We see some information coming from Italy as they get to the other side of the peak.
Thanks, Marina. There's a bit of an echo, and I'll ask the panelists who are not speaking to mute their microphones. And that may help the echo. There is a question from the audience. It said, thanks for all those numbers. Are there any statistics regarding type 1 and type 2 diabetes in your practice?
Any statistics regarding what? I couldn't hear that.
Type 1, type 2 diabetes.
That breakdown is not available. But I can tell you from, you know, what my colleagues are seeing in the hospital, many of the people that are intubated have a BMI over 35. And so I would interpret that to be that they're going to have some, if they have diabetes, it would be type 2.
Thanks, Marina. I'll let Antonio and Bassam.
Marina, congratulations. Very nice update of what happened there in New York, especially. My question to you is related with do you consider it going to be some differences between what are going to be the scenario in a private versus a public system there at the US? I mean, it's going to be managed in a different way at the public universities or private universities. You know, this scenario is going to be the same, change, because probably, you know, in the private sector, they're going to be most pushing approach to restart or to resume activity. What do you think about that?
I actually don't think that there's going to be a difference, because I will say that one thing that all the administrators of every hospital has realized is that surgeons and surgeries drive their cost centers and their profit centers. So I think all hospitals are in need to have cases restart. One thing that you brought up with public and private is when we look at the zip codes in the boroughs and where the highest caseloads are, there may be a bit of socioeconomic impact in terms of how frequently patients are COVID positive or that are getting very sick from it. So there does seem to be a distribution, which can also impact our public and private sort of hospital system.
Do you have an estimation, an estimated date, you know, your plans for starting activity, Marina, or not yet? It's too soon to think in a special date.
I will tell you that never have I been more proud to be a New Yorker. We have done such great physical distancing here, almost, you know, it's over 3 weeks right now, and I think that will flatten the curve. There is a Seattle, you know, one of the institutes has predicted that our peak in New York is going to be April 12th. I do think that that's close to it. I believe that we will peak this week end. Looking at our numbers and looking at what we're seeing is that there are less patients being admitted and that there are less patients that are maybe going on the ventilators. We don't want to say, I don't want to jinx anything, right? So, but it looks like we are getting toward our peak, which is critical to then determine when we're going to resume. My hope is to resume early May. I don't know if 3 weeks after our peak is enough time to start rolling out. However, at one of the hospital systems, they are going to look critically at cases that if we have someone who has high blood pressure, diabetes on multiple meds, and the system feels that we can do elective cases, that we can start to bring them in. Again, though I do feel that they will probably test them first before we do that.
Thank you.
Marina, I have a question for you. You're now in the epicenter of the storm, and we wish you and all the healthcare workers around you to be safe and healthy. Other countries like us, we're kind of preparing. One of the issues that's always raised is, do we have to have negative pressure operating rooms where we operate? Because most of our ORs are not negative pressures.
Right. So if there's a COVID positive patient, the institutions have designated negative pressure rooms to be used for those patients. So if they're not COVID positive, or if they were positive, but they're out 2 weeks, then they can be done in another room is the theory right now. However, we're not even getting into the laparoscopy versus laparotomy discussion. I think, that's going to probably come up during this webinar. But that is the current protocol in place for COVID positive patients. I do think negative pressure is better. Certainly we've seen that from Dr. Zheng's presentation, as well as what others in China have been talking about.
Some of the doctors have been exposed, so potentially or theoretically they should have antibodies. Are you checking if any of the healthcare professionals have antibodies, and if that's the case, are you bringing them back sooner to the front line of COVID patients?
So I can't speak for the hospital system. I've been effectively sidelined during this, so I'm not going into the ICU or the hospital to work. However, my colleague tested positive. There are different protocols in the city at the major institutions that are asking people who felt that they had symptoms to come in and get the antibody test. There are very small reports of giving patients the plasma from COVID positive patients, or people that have recovered, and giving them the plasma, and that it has significantly decreased the severity of their trajectory of their disease. So that is something that's going on at NYU. I know that Columbia has a protocol. I'm pretty sure that the other two systems, Mount Sinai and Northwell in the city, have as well. But that is something that the healthcare workers are being encouraged to go get their antibodies tested.
So Marina, I've had a number of attendees commenting on your optimism to commencing elective surgery again. One of the questions is, when you do start elective surgery, will there be sufficient PPEs available?
So at both healthcare systems that I participate in, we have enough PPE. It depends on what you consider, to be full PPE. I had to do an emergency case like the week after our shutdown, so about the 16th or 18th, I went in to do a laparoscopic appendectomy. I seriously considered doing it open, and the reason was to protect my staff because of the laparoscopic plume. But I ended up doing it laparoscopic because the patient actually needed our surgery. He is diabetic and he had obesity, and so it's the less injury to him would have been to do it laparoscopic, and we used the smoke evacuator for that case. I had enough PPE. They didn't test that patient because the tests weren't readily available for us at that time, and they thought it would be okay if I operated with a surgical mask, but I demanded an N95 respirator, and then I put the mask over it, and I ended up doing double gown, double glove, just to be completely on the safe side. There are many different protocols out there for what is considered best practice for PPE. And so you have to look at that. I think that as we all go through this, we can see what is going to be appropriate. We've had, head and neck surgeons and ER docs, as well as some orthopedic surgeons come down with COVID. Some of our colleagues have died. Some of them have contracted the disease and survived. There is a report that I had not been able to verify that there were 3 residents in New York State that died. I have to verify that before I say it, but that is a concern when it's our youngest and our brightest that are going out there to take care of this. So it is a concern, and I can't help but be optimistic. I mean, I'm a surgeon. I have to be. I'm an eternal optimist, but I do feel that by the early May, we should be able to start rolling out new elective surgeries.
Well, we're very glad to hear that, and we'd like to share your optimism. So thank you, Marina.
Welcome.
Thank you very much for your presentation.
Thank you.
I think Luigi might be ready, but before we do Luigi, can we do our third poll? Our third and last poll would be, what has been the toughest to experience during this time on a personal level? Select one of the following. While the attendees are selecting their poll, I'd like to say that this webinar is recorded and will be available on the IFSO Virtual Academy after this session. Okay, let's look at the results of this poll. Okay, so quite equal. The lockdown, downsizing my practice, and fear of work without protective equipment equally have been the toughest experience for most of our attendees. So thank you for that response. Now, I've been told that Luigi is not quite ready. So what we might do is we'll go on to MINEC, Middle East North African chapter. This will be presented by Dr. Khalid Mirza from Saudi Arabia. We know that Saudi is just starting to see the impact of the coronavirus. I looked up and I saw that the first case reported was the 2nd of March. And right now there are nearly 3,000 cases and 41 deaths. So very early in the experience, let's see what you can tell us, Khalid. Thank you.
Yes, thank you, everybody. Actually, now we have problems, challenges, and actions. Let's see what we have. Yes, if we look to this piece of metal, it means no value if it is just plain like this. It should have two phases, and each phase we should, yes. Well, okay, I'm sorry why it's going like this. Here, you see, my idea, this with no value. If there is a plane, it is just a piece of metal. It's not carrying the two faces. So let's go for the next. My idea is it should be, yes. So in current situation, all over the world, we have two groups working side to side. Medical group working to protect corona, and the security and police protecting the people, and both of them, they are saving their back each other. So the two faces of the coin should have healthcare, they are healthcare provider and the government. So let's see what we have in Saudi Arabia. Our population, as you see, 32 million. This is we have daily report at 3 o'clock, daily report about the situation in Saudi Arabia. These are the daily report. So if you see, this is yesterday. The total number yesterday was 2,900, with the yesterday cases 137, today 355, and the total death recovery 600, and today's report 666, and mortality yesterday 44, and today yesterday 41, and today 44. And the distribution of the cases, if you can see, it's in each city, the distribution is clear. So still we are going slowly, but not as other countries, very quick increase of the numbers of the patients. We look the history or the timeline of our situation in Saudi Arabia. I just came back to Saudi Arabia on the 29th of February. I was in Rome and Naples, and came back in 29th to Saudi Arabia. There was no any case reported there. So the 3rd of March here, when I came to the airport, they checked me and they sent me home. They said, no problem with you. But when I go to hospital, I receive a call to leave the hospital and go for two weeks at home. What is the good things here? Actually, they receive a call from Ministry of Interior. They called them, they said, you have a person who came yesterday or this few days, and please send him home. So we are, as a government, working very hard to control this issue. On the 3rd of March, schools are closed, suspended, and distant learning. On the 8th of March, suspending and entry to the exit to Qatif. Qatif is a city in the eastern province where the first cases showed up there. And after 1 week, they closed the whole city, no entrance and exit. We have a lot of doctors working there. They were not able to come to our area, so stay there and working from there. Next day, they suspend travel of citizen and resident to the countries of destination. Really, on that day, I have to go to Dubai, and I have my ticket at 3 o'clock. Before I go to airport, they said we close all the airport, so you cannot go to anywhere of the kingdom. Followed by closing and suspension of all the public areas, and again the government working hard, and they travel suspended to and close all the land port, so no transport through the kingdom. And again, the restriction getting more on 13th. It was very quick action and strong actions taken by all the public area, all the halls or the theaters were closed. Then international plan, again, in and out of kingdom, all sport activities. As you know, we have the most popular football games in the Gulf area, in the Arab area, very attractive, but still it was closed and competition suspended. So all these people coming back to Saudi Arabia, they were quarantined in the special areas, providing 11,000 housing units and hotels for quarantine. All these hotels, 5-star hotels in all the kingdom, distributed. So they receive them and stay there for 14 days. And nobody go out. Home delivery service observed and monitored by the government. Only few people, few companies to do this service, not everyone. All malls were suspended. Government work exactly, and security closed, so only the healthcare people goes. Our main important issue that would people go for prayer 5 times gathering in the mosque, and this is a very difficult decision for culture in the Middle East, especially. But we on the Friday prayer was suspended, and all the mosques were suspended. Nobody go and pray in the mosque, which was very difficult decision, but for the public health and prevention is very important. So we start to control the community first. You look the holy mosque, 2 holy mosques, how much used to be? It was 0, empty, and even the Mecca and Medina. So it is very difficult decision, but you have to do it because we know from the previous speakers and from the history how the controlling is important, controlling of the public. And the 18th of March, also all the private sectors were closed and all the businesses were closed for 15 days as a primary, and no salary deduction, and the government up to 60% of private sector compensated. So encourage them to stay home, and the government try to support this their living income. So again, there's more restriction. All the domestic flights now in the kingdom, you cannot go anywhere from by plane or even by land. So curfew was started, and from 7 a.m. to from 6 a.m. to 7 to 6 a.m. to 7 the whole day, because we did more restriction to control the disease from spread. This was also getting more restricted in all the public area, and the restriction become now, we are most 1 week, the whole cities of the kingdom 24 hours curfew only for important things. So what is the human, our aim is the human safety. So preventing you with all 13 administrative regions in the kingdom, no land, no air, and no 24-hour quarantine at home. Work attendance suspended in all governmental and private. So we have free medical service and treatment for all humans, locals, foreigners, and eligible stay also. So this is a very important step to take up. The Saudi Society of Bariatric and Metabolic Surgery announced that we have to postpone and cancel the private or in the private and public all the bariatric procedure until further notice. This is a recommendation from Saudi Society, and we start with a lot of guidelines published and sent it to be implemented from all the societies. And this is also for the guidelines for PPE.
Forse io questo il collegamento. No, perché
I will, yes. So this is a Saudi Ministry of Health protocol for adult patients suspected of or confirmed with COVID-19. So we all, the government published this and distributed to all centers. This is the protocol we are using. Suspected cases, clear protocol and detailed with indication and contraindication and precautions. It is a very nice 3 pages long to be presented here, but this is action was taken and distributed. This is confirmed cases, what to do, severe and critical. All the patients in the public health, in the ICU cold cases, all transferred to private hospital, clean private hospital to keep the public hospital ready to receive these patients, and all the elective procedures were suspended in the whole public hospital, except for some private hospitals. They send the government these patients to go there, which will government will cover the cost of these cases. We have all the ICU patients were in the hospital, we transfer to another hospital, private hospital, and the government will cover their expenses. So all the public hospitals were ready to receive these patients with their own protocol and guidelines. We don't have shortage of the equipment in this area because we started early, we prepared early to deal with this issue. Now the question, bariatric surgery, as I said, all the public hospitals, Ministry of Health, we suspend and postpone all the bariatric surgery and elective surgery, really. And all the clinic was started through the phone calls. We go to the clinic, we select the follow-up patient, and if there is a new patient booked, we can communicate by phone. At this stage, maybe in the few weeks, we start again to come back to the hospital to follow the protocol applied in China. So it is bariatric surgery, it is elective. And as we say, we see from other colleagues, the risk is high. If we want to do it, we have to have a more preventive protocols. It will cost this, but more safe. What about the business loss? We have a lot of private sectors, and if we continue like this, there is an increase, and this business loss will increase by duration, by time. So we have to think about strict guidelines and protocol to as early as possible to start the elective procedure. So we have to have strict guidelines, allocate hospitals for elective surgery, whether covered by government or insurance companies. Do we have to add special consent for these patients, writing that you may pick up coronavirus? This is a question mark, because if you tell him that we don't know you may get this virus, that most of the patients will go up. Is it medical legal or ethical? So a lot of questions and now challenges coming to our area, but still we are in stage of controlling and reduce the spread of the infection and acceleration to reduce the acceleration phase and to go early to deceleration phase and control. So it is both healthcare and government should work together and very hard to putting in their mind public and people's safety more than anything. So as we said, stay home for you. We are staying here for you. Please stay home for us. Thank you.
Great. Thank you for the presentation. I have a question from one of the attendees about Ramadan. How will you face that in this pandemic?
It is, we close the two holy mosques, which is a very hard decision. Ramadan will be same thing. It will be difficult for them, but still now we are all the kingdom, 24 hours we are at home. No allowed only for official thing. The question not only Ramadan, it is a plergium, the Hajj. I think until now, 60%, 70% the idea to this year Hajj will not going to be, but still we're waiting because it's very difficult. It is a very crowding area, more than 2 to 3 million coming in the same place. I think it is wise and a very difficult decision. I'm sure they will take the right decision to control this.
Mirza, congratulations, very nice presentation. My question to you is related with your very outstanding organization within the private and the public system. Do many or some surgeons focused on bariatric ask for working, helping the other colleagues? I mean, at the intensive care units or treating COVID patients? Are surgeons doing a different role as surgery?
As I said, in the government public, we are very strict regarding private sectors. If they are ready and well prepared, for example, I go to some of the private sectors from the door. They are ready to screen anybody come to the hospital and screen them, and even the operating room, as they said, negative pressure will establish and high class standard hospital. They may control, and they are doing elective surgery. But I think from this week, it would be an official order to hold the bariatric surgery, plastic surgery. This is the first one. Then the other elective like hernia, cholecystectomy, they're more important than plastic and bariatric surgery at this moment, until we provide a clear, safe guidelines to start this surgery.
I have another question regarding, the safety for the patient. Do you consider, or are you confident in your region to check before starting elective surgery that all the surgeons, all the surgeons related or involved in this elective surgery to have a positive immunity? I mean, all the determination of antibody against the virus? Are you thinking in having this condition before resume the activity?
As we said, we are still in the preventive stage, but it is we have to do something more aggressive and to keep the patient and the staff safety. If you don't do 100% sure everything is safe, you will lose one staff, get infected, all the other quarantine, and you lose almost 10 to 15 people. So we have to be sure. And as I said, some of this surgery is not mandatory. We can wait for some time. Because in our country, we are doing very fine in controlling the disease. Ministry of Health roaming in the area and avenues in which they focus, they go direct and examine the patient. So still, we are controlling now, but surgery, I'm sure we will make a very good, clear plan to keep patient staff safe. But if it goes.
And also, Ms., do you have any information, any data about related with the different other countries belonging to MENAC? I mean, Kuwait, Emirates, and so on. And do you have any information regarding that?
Yes, the MENAC area, we have 6 or 7 countries, 4 of them in Gulf area. We are following the same standard. Kuwait, Qatar, Emirates, and also Bahrain, we are following the same almost standard, and we're moving the same. Some countries like Egypt and Syria and Iraq, little bit reports not very clear, and the situation is different for but still they are following now, little bit late, but they are following the same standard.
Yes, Antonio, I can speak for Lebanon. So in Lebanon, most bariatric surgeons are in private practice. But we all have seen what happened in China. We all have seen what happened in Europe and what's happening in the United States, and we're all worried. So bariatric surgery has virtually stopped in most MENA countries. We have been blessed because we did not really, we were not hit hard with COVID-19. Now this was very good, but it's a double-edged sword, because that means we're going to have a flat curve that persists for a very, very long time. And the moment we let our guard down, we're going to have another peak of infection. So we should prepare ourselves for many, many months of inactivity. And here I have a question to all the participants. How do we fill this time? Do we do telemedicine with patients? Do we fix our databases in the meantime? Do we do more e-learning? I think we have to make use of our time, because we're all specialists and most of what we do is bariatric surgery. and this is going to be down for a few months. I'm curious what the other panels would do. What are you doing, Khalid, these days?
Actually, we are, as I said, we always ready for anything. They request me to send 2 or some of my team for training and intubation and taking care of this patient. Usually we start with the junior. Now they are ready in the front line and ER working there. They are a surgeon, but they are doing these things. And in case of emergency, we are doing. Personally, I go to the hospital ready for anything they want me to do to help, educational, taking care of the other area. And mainly now we are administrative. We are helping administrative. Because I'm sure one day if they need, because they will start the first stage, my junior is going. I gave them the name. I put my name in the list. If they need me, we will go. I know it is medical issue, not surgical. During Gulf War, we were in the front line. They were sitting in the ER, even the consultant, but we were really worked very hard during the war because the surgeon, that's our duties. Now the things changed. They are in the front line. We are supporting them. So we are busy in this way and education, university, tele-education, pictures, and these things.
Well, thank you, Khalid, for your sharing with us with your experience. I'd like to move on. I think Dr. Angrisani is back with his presentation. Earlier, I said that Italy has been unprepared for this pandemic. They've been through a tremendous heartbreaking experience with a huge death toll of more than 17,000. So I'd like to invite Dr. Luigi Angrisani now to share with us his experiences.
Hello, Lillian, thank you. Can you hear me?
Yes, we can hear you, Luigi.
Good, good. Sorry, this is has been a little bit complicated, and the presentation is a triangulation between my assistant that is down in southern Italy, Rossella Di Palma, and Nesrin Kidir from Qatar, from Doha. So she's sending the slides. So I think I appreciated very much this this seminar and this initiative, and one of the things I'm going very much concentrated is this intermediate period that we are going to face in the next few weeks regarding the bariatric surgery. Most of us, as many have said this afternoon, are doing bariatric and metabolic surgery that is basically stopped. So the point I'm going to address is how are we going to restart? How do we think to restart? This is a very old slides. This is in Naples at time of Spanish flu, where, as you can see, people were going with masks, and as today, special hospitals were built to assist people with this viral infection. And of course, at that time, in the 1920, as today, we have very little scientific evidence to decide and not only treatment, but also how to move on and how to proceed. And that's why I put the Hippocrates sentence that it is saying that you will do this based on your capability to the best of your knowledge, but you have not very much basic science behind it. So when we are going to watch the spreading of the infection in Europe, next slide. Hello. You see that in Europe, this is the European scenario. Of course, I'm afraid Spain is in front of Italy for number of infected people and almost the same for percentage of death, but what is very relevant and is that the different countries in Europe have a different percentage of infected people, a different percentage of mortality, but are also in a different period of viral infection. For example, in Italy itself, northern Italy, the Milan area and Venice area are much more affected than southern Italy. Naples and all southern Italy towards Sicily are minimally affected by the infection. Next slide. So if you see the level of spread and the level of control is variable according to each European country. And I think that I think I modify a little bit the European and American guideline, because American guidelines especially and European, of course, they claim, they absolutely declare that bariatric surgery is contraindicated, of course, in this time during this infection, but is also contraindicated, of course, in patients that are positive to the SARS-CoV-19 virus. So we are going, when the curve are flattening toward a transitional period. I define this transitional period as an appearance of some positive cases in less number and a less urge to fluid in intensive care unit. In other words, less people are coming to the emergency room and less people are going to ITU. So the American College with the ASMBS defined these three type of bariatric surgery. Emergency, that of course, emergency bariatric surgery needs to be performed at any time in any condition. But there are two, urgent semi-elective and elective, that can be discussed this morning, because there are, first of all, there are a number of urgent operation that become urgent, very urgent operation, emergency operation. So in that case, they needs to be performed. And there are other urgent operations that go toward chronic situation that basically become elective. I think I have added to the American statement banning trigastric migration, and mostly I have considered the problem of bariatric flexible endoscopy. That is a field some of us, myself and many others, do also bariatric endoscopy, gastroscopy and balloon placement and removal. That is something we need to address. Of course, at that time, we are talking of semi-elective and mostly elective operation. And I would like to define with you, next slide, what is the equipment that we need and who is the ideal patient for this transitional period. So basically, everybody is very much concerned of the severity of COVID-19 and morbid obesity. Antonio was mentioning the fact that we don't know if morbid obese patients are more prone or more vulnerable to COVID-19 infection, but certainly clinical sense and surgical capabilities need to imagine their own protocol based on their facilities to proceed in this transitional period. So we need to restart gradually we need to prioritize to clarify to ourselves and to our hospital administration who is first for bariatric operation. And when we talk about that, I would consider, and I would suggest to consider first the straightforward cases. So I would not consider complex, complicated diabetic patient with metabolic syndrome, hypertension, hiatal hernia. I would not consider revision. I would consider in the first, as soon as we will resume elective general surgery, the start of bariatric metabolic surgery with straightforward case. Next slide. So I think who is eligible according to our study, our document, because we are producing a document. I think at this stage, we would consider eligible asymptomatic patient without flu, of course, no fever, no GI symptoms, no history of COVID-19. Age, I would be between 20, I would go between 20 and 50, no comorbidities, no diabetes, hypertension, cardiac disease, not only because this comorbidity are more difficult to be treated when a patient may develop COVID-19, but because this complication may put the patient in the situation of going to ITU, and the last things you want is that patient goes to ITU. And no, of course, pulmonary disease, or sleep apnea, asthma, or of course, no smoking. This is the ideal eligible candidate. Of course, you need to do all outpatient, minimizing the time for the patient in hospital, medical history, body temperature, informed consent, very important. Perhaps I missed some of the presentation, but informed COVID-19, you need the COVID-19 informed consent, because people have to know that now, probably for next year and a half, whoever goes into a hospital may have a major risk, may have some risk of developing the infection. I have started to do this. People have to sign that they know they can develop COVID-19 after although they brief of hospital stay. We need to do the swab test, of course, or serological test. In Italy, it's not so available, the swab test. So we made based on serological test and radiological evaluation. I was very interested by the fact that I put, of course, X-ray, but I was more considering pulmonary ultrasound more than CT scan, because pulmonary ultrasound is less invasive. And for us, for doing in a 40-year-old lady a CAT CT scan, exposing the female, the young female in fertile era at radiation, a CT radio damage, it can be a problem. So I would not consider CT for all of them. So bariatric endoscopy is another field that need to be addressed, because also in gastroscopy, when we do investigation, we need to be protected. So now, of course, there are in basically two main kind of protection for the team, for low risk dressing or high risk dressing. At this time, if available, of course, the high risk dressing is much better. So to have a full set of antiviral clothes and hat and mask and cover shoes and everything. But otherwise, we could consider low risk dressing equipment if these high risk are not available, because one thing that we will have to address in this area is the problem of cost. How much is costing a diagnostic gastroscopy with high-risk dressing equipment. This is one potential problem. As well as, next slides, the problem is when you are talking of operative management, because again, you will have a patient that has a same-day admission. The patient should theoretically have a mask and gloves and eventually a cuff, and surgery, of course, can be performed by a team with a high protection set or low protection set. I am imagining that for cost analysis, we may have a sort of intermediate protection set. I think that there will be study to do on this, because for us in Europe, we are working on DRG. DRG is not covered. It's not covering the dressing, team preparation for this kind of patient. The room setting is very important because generally speaking, the operating room have a positive pressure system, while we know that the negative pressure decreases the risk of infection. And one thing that some hospitals have tried to solve this issue is to stop the ventilation, shutting down the ventilation for some time, creating some intermittent ventilation during the operation. So now I classify basically the dressing, the setting for the personnel based on different time when you handling the patient, for the team who is handling the patient. Of course, during anesthesia and when you do surgery and you do intubation, of course, you have a high risk of contamination. At that time, it's very important that we use N95 mask, double glove, shoe cover, water-resistant gun or an eye protection. We need all that. Next slide. Very important is the pneumoperitoneum. There is a lot of literature going on this, but generally speaking, you should prefer to have a smoke evacuator system. This is normally used in many operating rooms. But important to know is something I have discovered recently, that there is the risk of transmission is not only from patient to team, or what Antonio was trying to mention, possibility of team to patient transmission, but there is also the transmission from patient to patient through the pneumoperitoneum device. So how do we do this? We do having a filter. We need to connect the pneumoperitoneum insufflation tube and the desufflation tube with a filter. And there are various options available. I have read of some of those, although the one I'm more familiar is AirSeal. And AirSeal, in their AirSeal, as you know, have three functions, but the function to use that provide viral decontamination and purification is the smoke evacuation set. Finally, there is this ultravision that is an agent to decrease the aerosol particulate concentration, because this is, of course, the area of controversy. Second, another point is the technique we are going to use, because technically speaking, ultrasound vaporization cavitation technique, the classic harmonic ultracision, is the one who produces more possibility of viral spreading, while bipolar coagulation and radio frequency, we have Covidian with the LigaSure, and also N-Seal by J&J, that is a very good device that is not doing this kind of vaporization and cavitation that is dangerous for device. Next slide. So what we advocate, a very short hospital stay, so ERAS protocol are very, very welcome, generally are, but especially in this post-COVID era. Nasopharyngeal swab and serological tests should be performed at discharge, because from our side, we want to have, first of all, to know what happened at the time the patient is leaving the hospital. But mostly we need to have a legal document that says something when patient is discharged. Self-quarantine the patient after the operation. It is obvious that this patient need to accept that he goes on self-quarantine in his preoperative informed consent. And finally, we need to advise the patient that they need to be very well supplemented, especially if they have bypass surgery, but also for standard sleeve gastrectomy, because there is some vulnerability during the quick losing weight phase that the patient are going to experience. Going to the conclusion, I think you may see this picture of a desert street in Naples, like we are now, and the light of the sun may be interpreted as the sunset of COVID infection, or the sunrise of a new era for bariatric and metabolic surgery. I think we are going through a very delicate process that has to be gradual and prudent. Hospital must prepare specific protocol that arrange adequate training of the personnel involved. And I think IFSO needs to play a special role in advise the national societies, of course, taking at the first point that patient safety and medical personnel protection is a priority. Thank you for your attention.
Thank you very much, Luigi, for a number of thought-provoking statements there for us to think about as we get through this pandemic. There are a number of questions that have been put in by attendees of a recurring theme. One is that people are afraid to come to hospital in the time of pandemic, in the time of the coronavirus. So people with diabetes, people with obesity feel that they are at risk, and you may not convince our potential bariatric patients to come for their bariatric surgery while they could be at risk.
Lillian, I personally, I'm not finding this phase because you see, I tried to mention to you the other day that this kind of this kind of locking down situation is putting the patient in a situation they can only drink and eat, they are doing nothing. And I receive plenty of telephone calls of people that are worried, they want to do something, they want to absolutely to pursue with an appropriate treatment. Second, so I don't think he's going, I think there are a number of people that would be scared, but there are a number of people that have been thinking and maturing the decision of going to surgery that I don't think they are prevented by COVID infection. Secondly, what we have in Naples, and I hope this is going to be all over the world, that we have special COVID hospital. It means that there are hospitals where you got most of the infected patient. So you have hospital where they almost do not have, not even the emergency service They are hospital for elective procedure, where I don't see any reason you should not perform, of course, the low risk bariatric surgery, but why not? I mean, I think that when elective surgery will start, and we need to decide what to do, we need to start with basic operation. We are not going to do complex revision, from my point of view.
All right,
I'd like
time
to
is
hear
moving
your
on.
opinion.
I'd like a comment from Antonio and Bassam before we move on.
Yeah, Luigi, you know, I think you are very optimistic. I mean, you know, I agree with you that probably from the theoretical point of view, you can operate without no increased risk patient with a low profile bariatric surgery, I mean, sleep or so on. But the problem, in my opinion, my question to you is, are your patients ready for restart, you know, their bariatric procedure? Are they ready? Because in my personal opinion, they are concerned. They have fear of being operated for bariatric surgery, except that they're going to be more risk not being operating on them. And I don't. Do you think we have enough information regarding this topic?
Antonio, I don't know what is probably in Spain. The phase is still in the curve is not climbing down. It's not coming down. So you are still in a phase with active infection. But yeah. When I see in Italy, in northern Italy, especially in southern Italy, that the curve are flattening down. So there will be a time where we are going to survive with the viral infection. There will be the virus, and the virus will not be so active. So the infection will be confined, and we need to restart. I don't know. In my mind, we are going to restart. I have some semi-urgent case to do next week, but probably we will start some elective in May. Okay, but the problem is that 5th of May, somebody will give you an operating list, and you want to do some surgery. And we as a society, as an expert, as specialists that are doing this for the last 25 years, needs to discuss what to do first and how to do. This is a time for preparation. I understand that you may say patients are still scared. And Lillian was saying, oh, of course, but in 2, 3 weeks, 4 weeks, somebody will come up and say, Dr. Torres, Dr. Cow, we need the bypass, we need the SADI, we need an operation, and we need to know: are we doing SADI at this stage? I don't know. I do standard simple operation.
I think, Luigi, you know, in my concern regarding is again communication. I think, you know, our duty as a federation is to give enough information to the people, to the society, and I think this duty is going to be very important. And I don't think we are already ready for giving them a nice information, you know, for living up or living down, you know, their concern. It's my main you know, thought regarding this situation now. How to communicate properly to the society as a federation, the real data and the real approach to this new, very new and unknown disease.
But Antonio, there are no data.
Luigi, can I have a comment here? It looks like in the warm weather countries, in the temperate countries, the rate of infection is relatively low. And you can contrast Greece to Italy. Now, you showed a very nice slide on the 1918 flu pandemic. And if we have to learn lessons from that history, because it started in May, June of 1918, and it did not finish until 1920. And it slowed down in the summer, but then came back with vengeance in September. So I agree with Antonio that we should always be careful. Until we have a vaccine, we should really be careful in restarting our practices and do our best to screen patients in areas that have been affected highly, like in Madrid or in northern Italy. Perhaps if we measure the antibodies on patients, we make sure that they are immune, they are very safe to operate on. Otherwise, we have to continue taking very good history, maybe PCR on all patients, and maybe not go back to our current practice, just maybe start slowly and gradually.
Slow and gradually is my proposal, but I'm writing a document that I will submit to you all, to Lillian, to everybody. But do you think that at some stage it will be 3 weeks, it will be 1 month, it will be 2 months? We need to resume, we need to restart or not?
I just wanted to pop in real quick and just mention that there are reports out of Iran that patients who had bariatric surgery before have seemed to have a milder version of COVID-19 when they got infected. So that's actually very encouraging, because I think we have to also recognize that what we do this year will protect our patients next year. And it may be in part because obesity is an inflammatory state. And since we see the sickest patients are having cytokine storm, that perhaps decreasing the overall inflammation is very important to mitigating the severity of the symptoms and the disease.
So Marina, you are considering at some stage when elective surgery will reopen, when they will tell you you can do cholecystectomy, hiatal hernia, and I don't know, whatever benign elective surgery will restart, you will consider to restart in New York bariatric surgery?
100%. I mean, just that other people presented doing, simpler cases. If there's something complicated, I'm going to wait. But I think, with testing, if they're negative patients, and we can, really the key is to protect our staff that are around us and, that are there to work, but it's still a matter of protecting them. So, but we will restart for sure.
And Marina, have you addressed you have a system, is a different system, the problem of DRG, of reimbursement with the insurance? Because the hospital is certainly undertaking a cost for that operation that is beyond the normal cost.
There's still a profit margin there, and that becomes a financial discussion, but the hospitals want us to work. They want us to do cases. They are really recognizing how important surgeons and surgeries are. And these patients aren't going to the hospital to have surgery. In New York City, most of them are coming to a specific surgeon, like myself, my colleagues, Dr. Fielding, and Mitch Roslin. They're coming to Diego Camacho. They're coming to names and Mark Bessler. I want to name all my friends and my competitors, but but they're coming to us. So that the hospitals are starting to recognize that, and they're going to make sure that we can have the throughput to do the cases for sure.
Good.
So thank you, Luigi, for starting a very interesting discussion. I think we must move on. Do remember that this is the first of our webinar series. We have plenty of other webinars that we will continue this discussion. So I'd like to invite our least but not last speaker, Dr. Almino Ramos from Brazil. I note that the latest figure in the last 24 hours in Brazil has shown the infections jumping from 13,700 to nearly 16,000, and the deaths went up from 667 to over 800. This is by far the worst result for a single day since the coronavirus reached Brazil. So thank you, Amino, for joining us and sharing with us your experience.
Hello, Lilian. Hello, everybody. My pleasure to be here. Let me see, how can I share my screen? Okay, wow. I think Manuela should authorize me to share my screen because I'm not able to share. Yeah? Okay. So can you see my screen?
We can see you, but not the screen.
Mm.
You can see the screen now.
Oh, okay, thank you. Great. So let's see and try to explain to you what is happening right now in Latin America regarding the COVID-19. I don't have any disclosure related to this presentation. So in our region, we have 20 countries, and Latin America is about 6% of the world population and 13% of the world area. Even that we have 20 countries here, we don't have all of them, including in IFSO, a Latin American chapter. So in IFSO Latin American chapter, we have 17 countries. And based on this study published by Angrisani, Luigi, that is with us right now, we are responsible for about 25% of all worldwide bariatric surgery. When we go to the list of COVID-19 worldwide numbers, and we have here the 10 major numbers, you see that we don't have any country from Latin America. Brazil will appear as the number 14 country in terms of number of cases. And here you have an idea about what is happening in Latin America regarding the number of cases. Of course, Brazil regarding the population is the major country. But as we have discussed here, some of the reasons for these numbers can be related of testing. So you can see that our second country is Chile, but maybe it's because Chile is testing much more than other countries in Latin America. So this is the reason that Chile appear here as the second country. But this problem is increasing in Latin America. In the preparation for the pandemic, we have an expectation for a huge number of patients, an increasing and progressive hospitalization rate, a lot of necessity of ICU, and this will be by the experience coming from other countries for a long time, 10, 14 days. A lot of use of mechanical ventilation. We are very afraid about the number of protection PPE that we have, that we will need a very huge extra utilization of PPE. And of course, we have projected thousands of deaths related to this disease. And it is expected in some countries a total collapsation in the healthcare system, maybe the public one. So this is our Brazilian Minister of Health in the day when World Health Organization declared the pandemic regarding the COVID-19, and this is our main television net in Brazil. And unfortunately, when the minister told this first message regarding the pandemic, he said that we should stop all elective procedures in Brazil, and this is for all Latin America. I think it's the same. And he talked specifically that the first procedure to be interrupted should be aesthetic plastic surgery and bariatric surgery. He said on TV the word bariatric. So in the preparation for this pandemic, all elective surgical procedures should be suspended and plastic
We seem to have lost Almino.
Yeah.
The screen is frozen.
Comunque dal 1° luglio mi avrò perso.
Hello? Lilian?
Luigi, I can hear you, but I think Almino is frozen. I'm going to get Manuela to ring him to tell him that. Perhaps while we're waiting for him to come back, we should look at some discussions or some questions that is...
Exactly. No, I was just watching this slide, this Almino slide, that all elective procedures suspended, plastic and bariatric, top of the list. This is something that is very much. I don't like it, because I don't like that we are compared to cosmetic surgery. Because if you tell me that you are going to have breast reconstruction for cosmetic reason during COVID-19 infection, that I have also seen this. I know that there are people that are going to ask for plastic surgery during the COVID-19, and I think that this is too much. And I agree
with you, Luigi, but the authorities think in a different way. You know, they cancel plastic, bariatric, and this kind of surgery. They don't distinguish between obesity, bariatric surgery. You know, politicians always do the same.
But that's better, Antonio. That they don't. If you tell me elective surgery is stopped, I don't say anything, and you do only cancer and emergency. Fine, I agree. But when you open to elective and you will do achalasia, you will do fundoplication for reflux, you will do cholecystectomy, you will do resection for diverticulitis.
No, Luigi. This slide means that in the list of elective surgical procedures, including cholecystectomy, achalasia, and so on, plastic and bariatric are on the top of the list. There is a big list. Only a section, as he said, put there. No, it's like he put the oncology and emergency. I have to comment, Lilian, something about one question that Manuela put in the WhatsApp is regarding. We have had some patients operated by bariatric surgery that have COVID-19 positive. They are being treated in the same way that the other patient. and they are doing well. We had a couple of them admitted at the intensive care unit, and they recover properly. They are now discharged from the hospital. But the question is, are those bariatric operated patients suffering from the COVID-19 treated in a different way? I would say, at least in my country, in Madrid, no, they are treated the same way.
Yep. Also, with a comment from Marina, particularly with bariatric patients who may actually be less susceptible to COVID-19. I think that's something we need to look at this, with some more data that's coming in. We could make a case that as we recommence our practices, bariatric surgery patients might be better off having their surgery and be more healthy to cope with further illnesses. So
Absolutely.
We should bear that in mind and not let agencies, governments, and particularly insurance companies stop us from restarting bariatric surgery just because they're morbidly obese.
I think in our region, in our hospital, even the private and the public, obesity is a negative prognostic factor because regarding when those patients with obesity are admitted to the emergency room or the intensive care unit, to manage them from the respiratory point of view, it's more complex than the non-obese patient. We don't have data because I think in the future, at the same time, we have this range of old people having a worse prognosis. For sure, in the future, we will have, obese people within this range of negative prognostic factors. It's my personal feeling.
Can I comment regarding for Dr. Luigi? Yes, your proposal is nice and good to review and study it and focus in. But I would like to add something. The operative time would be short as possible. So if we add that the procedure in the beginning should be done by a senior anesthetist and senior consultant to reduce the operative time. No training, no junior in this period. So I think we add this as one of the recommendations to restart, if we were to restart.
Absolutely. Totally agree, Khalid. Totally agree.
A follow-up on this. As you know, some of us are in university hospitals and we are in charge of training our fellows. A lot of the programs will have fellows with several months of no clinical activity, and this is going to be important in some of the training programs. The other thing, as bad as COVID is, I think it's bringing us an opportunity to learn new things. One of them is the focus on telemedicine. I think it's a good opportunity for all bariatric surgeons now to invest in seeing their patients online, following them online, trying to do more educational things online, and try to minimize their outpatient clinics and decrease the density in the clinics. Online applications will probably be also important for us in the near future.
Regarding this situation, but then I think we will have to take care of the face-to-face scenario to operate on the patient. We will have to have some safety implemented measure, like to do PCR on the patient. For sure, in every patient we're going to be operating the next days, and for sure probably to have some surgeon tests for be sure that we are doing a safer or a very safe surgical approach to our patient. So I think we have to generalize the checking the antibody against the virus when it's going to be available in all the centers. It's going to be the best way. Waiting for the vaccine in the future, but I think at this time, we have this antibody checking going to be very nice.
I think that's a very important issue. Until we have the vaccine or a cure for COVID-19, we need to proceed with caution. We don't want to be resuming bariatric surgery, find one of our post-bariatric surgeons, patients develop COVID-19 and then die from it. You know, the news will be that not they died from the COVID-19, but because they had bariatric surgery. So we must be very careful.
Dr. Bassem Safadi, regarding the outpatient, we already started in our public hospital and private virtual clinic. So we go and we prepare the patient. The priority in this virtual clinic for follow-up patient, not new patient, especially in bariatric. So we have a list every week for the patient, follow-up patient. We go and virtual clinic. We communicate with them by phone or through the website, and even the medication refill we send and delivery. We have a home delivery for medication. If they are unable to come or in quarantine area, we have the system of home delivery their medication renewal. And
sorry, I'm back.
Yes, Almino's back.
The technical problem I had. So I will take 3 minutes to finish. Manuela, can you help me with sharing my screen? Yeah.
Well, we see you, Amino, so we just need to see your screen.
Yeah, let me see. I'm trying to share, but it's not possible.
Yes, now we are seeing your screen, Dr. Ramos.
Oh, yeah?
Yes, we can see your screen. Just need to...
Okay, moving?
Yeah, we got that.
Okay.
Yes, we see it now.
Okay, so by medical decision on regarding societies or country regulations, we suspended our bariatric surgeries. So because of this, we cannot attend our recent postoperative patients. There is no multidisciplinary team consultation. We have to suspend or postpone scheduled surgeries. We don't have exams available right now, endoscopy, ultrasound in regular unities in Brazil. These are dedicated just to COVID. No new patients and a poor follow-up of the patients we have right now. And we had in Latin America a lot of misinformation from the patients. Patients are afraid, fear and apprehension about immunologic repercussion of to having a bariatric surgery, about how weak they will be because the weight loss, irregular follow-up, and this will increase my risk, problems with supplementation. So we had a lot of questions by phone, by WhatsApp, coming from the patients with this kind of misinformation. And we have to think about the economic consequences of the approach of the pandemic with social isolation, lockdown, keeping just the essential service, severe economic problems, unemployment, drop in our gross domestic product, coming back a big inflation, decreasing capacity to pay. So if we have our healthcare system collapse, we can have also an economic collapse. And we did this study. This is from my university here, Unicamp. We published this in 2018. When we compare here in Brazil, the growth in the gross domestic rating in Brazil and the number of bariatric surgery, and we have a very close relation regarding the economy of the country and the number of bariatric procedures we can offer. So in the future, this will be very important in Latin America because we have a lot of economical consequences when we have conditions to restart with the procedures. So I think we should try to have a strategy, and Luigi and Marina, they pointed something, but in my mind, step one, reconnect with the patient. We have operated patients that we should continue to follow these patients. Recover the confidence level of the surgery, look for evidence of immunologic improvement with bariatric metabolic surgery, priority to have operated patients back on track in an adequate follow-up, create conditions for having new patients, organize and effective and easily as available, the use of telemedicine program and remote consultation that we are discussing a lot and implementing this in Latin America, including the accessibility to our multidisciplinary team. Step two, create possibility for restarting with surgical practice. We have to define the rules of safety of procedures with this in this time with COVID-19. We have to define the rules with patients and family. We have discussed this, the informed consent with our surgeons and operative teams and all the healthcare workers. We have to define safety to work for these people. And the step three, that is continue providing the real value of bariatric metabolic surgery as a safe and most effective therapy for obesity and metabolic disorders. We have to discuss this with our payers, with insurance companies, general community, medical community, our peers, our partners in the hospital, and the general media. So COVID-19 will come, stay a while, and leave. This will be just one more barrier we should overcome. In the past, we have surpassed a lot of them one by one. With science, resilience, honesty, we will prevail again. Thank you very much for having me in this meeting. It was a big pleasure to participate.
Thank you, Almino. I think you've summarized this very well, that there is optimism in this pandemic. We will conquer this pandemic and we will come back to some form of normality again. Antonio and Basamdu, have you got anything to ask of Almino before we finish this seminar?
Yes, I have to point out, congratulations, Almino, very nice message. I think, you summarized all the talks we have been discussing here. But my question to you is to point out how important is the communication. You said, especially in Latin American area, IFSO American chapter is plenty of misinformation. Even in your country, the conflict between the president and the Minister of Health, in the different media, it's going to be even confusing for the population or even for the patient. My question to you, Almino, is how can we improve the communication with the different protagonists you mentioned in terms of decreasing the misinformation? What are going to be our next step forward? I mean, social media, journalists, TV, with whom are we, or do we have to talk to?
Antonio, I think that that's a very important concept. And you see, I have a son that is 10 years old. And of course, he is at home, but looks like he's having the same kind of life because he has schools meeting with the teachers online. He used to meet every friend by internet, a lot of online appointments all the day. He is in the computer communicating with the world. So these guys, the young guys, they are keeping the same capacity to communicate, and we have to use this capacity also. And I think our priority in this moment is to reconnect with our patients. We have compromised with our patients. We have patients that we operate a month ago, 3 months ago, 3 years ago, and they are worried about what happening. So I think we should unite our societies. Remember that IFSO mission is unite. And we have right now Lilian, our president here. We are starting with these webinars. I'm impressed with the success of these webinars. We have people from different parts of the world. We are crowded. I missed the connection in the beginning, and I was not able to come back because the webinar is full. So let's increase, let's change the platform, let's have more people, let's reconnect, let's restart. We have to restart, start over again.
Well said, Amino. This webinar certainly had more attendees than we intended. At the beginning, I was told that there were 1,500 registrants to this webinar, which is far more than any number of the webinars that we've had. Perhaps it's because of the topic, the coronavirus topic is very much in every one of our minds, and therefore we want to learn from each other. Tonight is a perfect example. We've learned from the different chapters, we've learned from the different experiences of each of the speakers in terms of where they are on that curve. I've certainly learned a lot, and I'd like to thank all the panelists and the discussants for their contribution to tonight. And I'm sure the attendees have also learned a lot. I'd like to say that this webinar has been recorded and will be available for anyone to peruse on our virtual academy on the IFSO website. Lastly, I'd like to thank Ethicon Johnson & Johnson for sponsoring this webinar, for which that they have been a very strong supporter of IFSO as well. So thank you to Ethicon. So once again, thank you very much. A 60-minute webinar has gone on to almost 2.5 hours. So thank you everyone for your interest, and a number of many questions have come in. I'm very sorry that we could not answer all of them, but do tune in to our next couple of webinars that we have ahead of us. We will be continuing this discussion, and we will continuing this discussion in further detail. So thank you everyone
Lilian,
for your attendance.
You know the reason, Lilian, we are missing a lot each other, huh?
That's right. So we like to reconnect every now and then as much as possible.
Right.
Yeah.
Thank you.
So once again, thank you everyone for participating, and thank you for all the attendees for listening in. And we will recommence in about 2 weeks' time with our next webinar. So
thank you.
Good night or good morning to everyone.
Bye-bye.
Bye-bye.